We still got a minute. One thing that I'll give you guys a head start that are already on, that if you so choose, you do have the option of changing the name on your screen. And if you want to, since a lot of us know each other through Instagram, if you want to put your name followed by your Instagram name, that would be kind of cool. And people might recognize each other a little bit more. Mine doesn't all fit on there, but maybe I'll change mine to something shorter.
I just saw Fred behind you.
Yeah, Fred. Oh, and Ella left.
Ella left. Ella.
She's the best cat.
Agreed.
Fun fact, Ella is also a hermaphrodite.
Yeah, that's right.
Special lady, man.
So special.
No, I don't know what she preferred.
Is she true hermaphrodite?
She might actually be. I can't remember her blood tests. It was a long time ago when she wasn't ours. Might have been more male than female, actually, even though she kind of has a cloaca, so we call her a male. Hey, Sean. So many
but
people.
She's so cute.
Ooh. Okay, I'm going to share and we'll get started because 11 o'clock and people's time is valuable.
Yeah, and people are just kind of cropping in, so I'm just kind of letting them.
I'll just do just a quick intro since we're being recorded. So we are being recorded, and the chat will not be on the recording, but I do have that just saved. If anybody has any questions or if we ask for information, we can look at that as far as like polls or questions or anything like that and get back to you. So just so you guys know, if you don't want to be your pretty face on a recorded thing, I don't know who's going to ever look at this, but then you can keep your video off. And we will, during the presentation, if people can take their videos off, it just makes the PowerPoint run a lot smoother. And mute also, unless you want to have something to say. We'll be watching the chat and jumping in as there are questions, so don't hesitate to do that. And we might unmute you to ask you if you want to explain better or something like that when something comes up. So, welcome to CAT class. This still has Friday on there. I forgot to take that off. But today we have Lo Curtis. Tomorrow, myself and Dr. Crocker and Dr. Rongren are going to be talking about mentorship in general. And we would love if you have questions to direct message myself or Kirsten at Vet Redefined, or even Dr. Crocker at hers, Dr. Tanisha Crocker. I think she's working today and tomorrow, so she's going to be a little bit busier to be able to get back, but I should have time to compile those and make sure we answer them tomorrow. And then on Wednesday, Dr. Rongren and I will be leading Q&A mainly. I'm going to have a short presentation about handling that was also in some of it, not all of it, was in my talk on Friday afternoon. It was a little bit of a bonus deal, but I've gotten a lot of questions about handling, and I think people are freaked out in general by cats if they haven't had much contact with them, and in the teaching hospital, it's really, really hard. So we're going to do a little bit of that, and then just Q&A on medical practice stuff, new grad coming into and working with cats, that kind of stuff. So please, 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 and I'll send a request on Instagram, send me questions or things you want to go over. And I've already gotten a few, and we'll get those answered on Wednesday to kind of get a catch up. Dr. Woolner, she's a really, really good speaker. She's been in practice. She's in industry right now, but she's going to do and I just got the title from her, she's going to do a talk on what I wish I knew. And she's really, really good. So don't miss that. It'll be entertaining, it'll be informative, and it may not be as specifically cat focused, but it'll be great stuff. And then we got Dr. Ashley Berger on from at the Derm Vet on Friday, and I'm really, really excited to hear her lecture then. So we got a good lineup. I don't know if we're going to be doing it next week. We'll see. We'll see what kind of what people want, and and where it goes. I'm going to do tomorrow's next. So I'll come back to this slide. But tomorrow with mentoring, there's just the links to Dr. Crocker, Dr. Rongren, and myself. And I think it'll be a good cross-generational discussion. And because there's mentoring is wide, and it's a wide topic, lots of stuff to go over, and it'll mainly be just a conversation, so be prepared for that. Okay, go ahead, Kirsten.
Okay. So just for those of you who are kind of hopping in now, a reminder, if you can make sure to, I think I can see everybody, just make sure that your microphone's muted. And we have found that with how many people are using Zoom right now, that Zoom is like brain exploding. So if you have your video off, it just makes it run a little bit better, a little bit smoother for everybody so we can hear. Like Dr. Marshall mentioned, we are continuing through the rest of the week. We have a really good schedule this week, and I'm really excited about it. We may have some more next week. Honestly, it kind of just depends on the demand and the topics that people are interested in, because I think we could easily go a third week with people and topics and things like that, but it really depends on what you guys are interested in. So we will come back to that. As of now, I've had a lot of people, somebody just asked about FIC and Flutie. I would love to talk to you guys about that. I would also, or I'm happy to find an internist or a cat person who would like to talk to you about that. I really like talking about lower urinary tract disease. So whatever works for you guys might be tired of listening to my voice at that point, but we will cross that bridge when we come to it. So as far as that goes, we will let you guys know. I've had a lot of people emailing and messaging me about when the recordings will be available, because I know that people have missed a couple here and there, or will be missing some this week. Dr. Marshall and I are still kind of figuring that out. We're trying to figure out the best place to get files uploaded to. And I think that as of now, what will probably end up happening is that I will be embedding these onto my Vet Redefined website. So once that is done, we will let you know, and we'll let you know where you can find them. I've got a couple other people popping up things in the chat about arthritis management, especially kitties, IBD, feline lymphoma, feline oncology, and nutrition. So those are all things we've had on our list.
I guess we're going another week.
Yeah, I know. So these are all things that Dr. Marshall and I, excuse me, don't listen to my dogs barking. These are all things that Dr. Marshall and I have talked about as far as ideas go. So please do not hesitate. If you guys have topics that you're interested in, let us know. The other little announcement that I will make as far as for Wednesday's lecture, the one that Dr. Marshall and I are doing Q&A, essentially that Q&A is pretty open. So that is meant to kind of be a free-for-all. I think that it will turn out really good, because I know that a lot of people have either had follow-up questions to lectures that we've given so far, or have things that they want to talk about, and that it can literally be about anything. So if you guys are starting to come up with questions, please either email or message myself or Dr. Marshall with those questions, because we will be preparing information for Wednesday off of that. But I'll also be watching the chat as we go. So something to kind of keep in mind. I think that'll be really fun.
One last thing before you introduce Lo,
Yeah.
is if anybody has friends, contacts, I know I do, but I don't know where I don't remember who they are, from the continent of Africa. So maybe I know I've got some South African friends, but I can't remember who they are. Because that's the only continent besides Antarctica that we haven't reached yet with cat class. So I'd like to message them and let them know about it. So if anybody has any friends, send me a message or put it in the chat, or just invite them to come along. That'd be great. Okay, that's all I got.
Excellent. Perfect. So without further ado, because you guys didn't come to listen to me today in my jammies, I would love to introduce the speaker for today, who is one of my most favorite humans on this entire earth. She is a very long-term friend of mine. Her name is Dr. Lo Curtis, and she is a veterinary neurologist who now is living in Austin, which I still need to come visit her, but since we're on lockdown, I have to postpone it. She graduated from Washington State University College of Veterinary Medicine the year before I did. And we have been fast friends since then. And I cannot wait for you to listen to her. I won't tell you too much. I'll let her tell you about herself. But she's going to drop some neuro smarts for you. If you guys have questions, I'll be watching the chat box. You can type them in there. But I think you're going to love her because she's awesome. That's all I have to say about that. So we are going to get started, and Dr. Curtis is going to drop some knowledge. Hi, pretty. Welcome.
Hi.
Hello.
Are we able to stop sharing so that I can see the grid? Thanks. I didn't want to stare at like myself while I'm talking.
It might just be looking at me and Dr. Marshall.
Yeah, that's perfect. So I want to do a couple of disclaimers before I forget. One, I'm very much like a freestyle type of speaker, and I don't have a PowerPoint, and even if I did have a PowerPoint, I wouldn't be able to share it with you because my laptop died, like solidly died 2 days ago. So all the videos that I was going to share with you, it just felt too overwhelming, so I'll just act it out. Just kidding, I'm not doing that either.
I'll volunteer.
So I'm also not going to pay attention to the chat because I'm like a squirrel and I'll get really distracted. So if you guys have any questions, because I would really love this to be like as interactive as possible, if Kirsten or Dr. Marshall could grab questions from the chat and then just ask me, and then we can go through that. I think those are basically my disclaimers, besides the fact that you might hear dog noises. So. But we're all vets here. It's fine. Yeah, so a little bit about me. I'm originally from the state of Washington, and I say the state because I lived on like the west side, and I lived on the east side, and all over Washington State for the majority of my life, except for my rotating internship, and then obviously now. So actually like my favorite thing about my friendship with Kirsten, I guess maybe not my favorite thing, but what I think is really interesting is that she and I met very briefly while we were both at undergrad at Washington State. Didn't really get to be good friends until we were both in vet school, but her mom is actually the veterinarian who wrote my letter of recommendation to get into vet school, because I shadowed her mom when I was in high school, and Kirsten and I actually went to rival high schools in high school. So like we were just fated to be friends, I think. And I knew that Kirsten existed in high school because I knew that the veterinarian who I was shadowing had children, but that's pretty much the extent of it. So to some degree, I've had a Dr. Rundgren in my life for a long time. So I went to undergrad and vet school at Washington State University. Go Cougs, best vet school in the whole wide world. Don't at me, because it's not, it's just a fact. And then I did my rotating internship at a private practice hospital in Northeast Ohio, and then I came back to the Seattle area. So Linwood, Washington, for those of you who are familiar with the west side of Washington, for my neuro internship. Stayed on there for my neuro residency, which I completed this past June, and then moved to Austin at the beginning of this past fall, for my first job as a big kid as a neurologist. So I'm very freshly out of residency, and I have a lot of thoughts and feelings about residency process and the match process. And if anyone is like curious about the private practice aspect of internships and residency, I would love to speak on that as someone who previously was very, very much like, I want to do academia and I only want to do academia. So that's not really what I was coming here to talk to you guys about today, but just saying I have some perspective on that as well. So feline neurology. I think feline medicine in general can be intimidating, and then I think neurology in general can be intimidating, and then you put the two of them together, and depending on where you're practicing, but for the most part you'll see so much more canine neurology than you will feline. So then not seeing it also makes it kind of intimidating, because you just don't have that many opportunities to get really good at it. So I don't have a ton of specific things that I wanted to talk to you guys about today, because I feel like, again, I said I think question and answer is sometimes a little bit easier because I have a very different perspective, right? The things that are interesting or nerve-wracking to me are not necessarily what's interesting or nerve-wracking to students and general practitioners or referring veterinarians. So, but I did get a lot of feedback from people that they wanted some tips on doing a feline neuro exam, and without being able to do a hands-on demonstration for you, I can do that to the best of my ability. And then I'm not shocked by this at all, seizure management. I think seizures can be really intimidating as well. Not for me necessarily, because I do it all the time, but that is usually the feedback that I get from people, is that they want more talks about seizures. So I'll talk a little bit about that, and then as questions pop up, I also think vestibular disease is really prominent in cats, and I actually just recorded an episode with the dermatologist that will be on at the end of the week. She and I just had a conversation for her podcast about otitis media interna, which is typically what I see cats for. So when that episode comes out, if you're not already following the derm vet, follow her so you can listen to that one. We have, she and I are both a little bit like squirrely, and so it's an entertaining discussion, to say the least. Oh, she's on today. Hi. Yay. Okay. Yes.
Guys,
so check that out. And I'm sure her talk on Friday will be phenomenal. Okay. So the feline neuro exam, I will say cats probably, so this is my advice for both cats and dogs, is that do not forget to do a hands-off exam. And it's really tempting, for myself included, and I do neuro exams every single day for the past like 5.5 years. It's really tempting to immediately approach the patient and start touching it and doing your exam. And it's, I think, important to do the hands-off portion first so that you don't forget it. And because when you start touching the patient, especially a cat, you might start ticking it off, you know? I think cats, you have, unless it's like a really, really good cat or a really afraid cat that just like kind of becomes paralyzed when it's afraid, you're going to have fewer minutes before that cat becomes not touchable. And unfortunately, I think in neuro situations, it's hard for me to use a lot of the fear-free principles. Like, it's hard for me to use treats and things like that because for the most part, when I'm doing it, I might be doing anesthesia. Now, I don't think that that's necessarily relevant for you guys. So if you are fear-free certified, I think that that's a really great way to do these exams. Anyway, I digress. That's a whole different thing. So the hands-off exam, the things that I look for in a hands-off exam are things like mentation. Is the cat interacting with its environment in a normal way? I usually, when I can, I set the cat on the ground and watch it walk for a couple of reasons. One, because I want to examine its gait. And that can be hard. I can definitely appreciate that because a lot of fearful cats will just crouch to the ground, and it's hard to appreciate if they're uncoordinated or ataxic. But I also think that it's a really good mentation check. When I have a cat that's walking around and looking for a place to hide, to me it's like, oh, that cat's mentally appropriate, because that's what an afraid cat should do. So I always joke with my techs when they, when they try to go under the shelving and stuff, that, oh, mentation check. So yeah, mentation, gait, and then just in general, how they're interacting. Posture is also something that you don't need to touch your patient in order to evaluate. And by posture, I mean things like, is there a head tilt? Is there a head turn? Do they seem hyperextended on one side, or are they able to get up? The inability to stand is a posture comment. So that's, I think, my biggest first thing is with cats in particular is really utilize your hands-off exam, because I've had some patients where they're so fearful that I can't really do a hands-on exam with them, and I have to be able to try to localize without touching the pet, which I wouldn't necessarily expect a non-neurologist to do, but I think it is actually possible. So things like gait, if they have a head tilt and they're falling over to one side, you can localize that to the vestibular system. And then whether it's left or right is probably academic, unless you're going to be recommending like a surgical approach to that or anything like along those lines. So the hands-off exam for cats is really invaluable. And being able to do that somewhere where it's an empty room or in your exam room, and sometimes even removing chairs or things that they can hide under or go behind so that you can really get an idea of their gait. Sometimes with cats, if it's not a cat that's cooperative for doing things like placement correction or reflexes, or even a cranial nerve exam, I'll try to do the most that I can, again, without touching the patient. So I'll assess vision. I wish that I could just give this whole lecture in person with all of you guys to show you, but like I'll dangle my stethoscope, and I'll have my stethoscope be from behind their head and then slowly move it forward. And once it's in their periphery, if they're visual, they should look over at it on both sides. So I'll do things like that to assess vision. If I can, I'll use the longest hemostat that I can and kind of tap at their palpebrals to try to do things like their cranial nerve exam. So those are kind of honestly the biggest tips that I have as far as doing the neurologic exam in a cat is just go slow. Don't forget that your hands-off exam is really actually very valuable. And then trying to do things, you can do some things at a distance. And honestly, if you can't get reflexes, but the cat's coming in for seizures, it's probably not really worth trying to get like, oh, does the cat have patellars? It's probably not going to help you in making a differential list and a treatment plan. So abandoning the things, if you're not able to do a full neurologic exam, giving yourself some grace to get the information that you need and trying to prioritize that, I think is helpful. Are there any questions about that or up to this point?
So far, I think everyone's picking up what you're laying down. I haven't had any questions coming up. I'll give it a second, but those are so good too. And I think the other thing that made me think of, Lo, is that I also feel a little bit like that. Same concept with orthopedic exams in cats. It's kind of the same thing. It can be so difficult to evaluate in kitties sometimes because their first instinct is to just slink across the floor and go hide in the corner or scanner under the chair. So
yeah, and if you have a cat that is fearful and crouched, so it's difficult to do things like proprioception, like to check their placement correction. One thing that you can do that's not exactly the same thing, but will still give you some insight, is if they'll let you pick them up and then you hold them, but you bring them towards a table, and they should put their paws out and step. So if you can't get them to let you touch their feet to flip them over, you can try doing things like hopping and wheelbarrowing, which of course is easier said than done. It takes practice. I wouldn't stop trying to wheelbarrow things because you're not good at it, because you'll never get good at it if you don't continue to try to do it.
We do have one question that did pop up. Maya says, does the owner presence ever affect these exams?
I don't do my exams in front of owners. My exams are always in the back where I have space and a technician holding. I know that's not always the way that the workflow is. I will do owner present exams when the owners insist upon it. And usually it doesn't. And I think it's really important to walk the owner through what you're doing. So when I do have to do owner present exams, I will let them know, the point of my neurologic exam is to answer a few questions. First, do I believe that your pet has disease of the nervous system? 2, where would I localize that? Brain, spinal cord, or neuromuscular? And then I let them know, what I'm going to be doing is testing reflexes nose to toes, that my exam is designed to be annoying, and so some of the things that I'm going to do they're not going to appreciate, and that when it comes down to it, I will be trying to localize discomfort, and by doing that I will have to elicit pain, and letting them know that. And then I always also bring a technician in with me, because neuro exams are really hard to do. A really good thorough neuro exam, especially in a painful or fearful patient, is sometimes really hard to do solo. So if that's something that you're able to do in your practice, having one of your technicians come in, if you have a patient that's presenting for neurologic disease, doing your general physical exam, because I want to emphasize that it's still really important to do a general physical exam. There are lots of neurologic diseases that are actually manifestations of systemic disease. And so, I feel very strongly that as a neurologist, I'm still a veterinarian first. And so it's important for me to look at the patient as a whole pet, not just a nervous system with muscles and bones and liver and kidneys and things like that. You know, it's a whole pet. And so then I think the biggest thing is just communicating with your owners what you're doing. So when you're checking a menace, explain that, you know, I'm doing this menacing gesture because if they're normally visual, they should blink and pull their head away. I am testing the palpebral reflex to see if they can feel and move their face. I'm flipping their feet over because I want to get an idea of whether or not they've got good spatial awareness. I'm checking their reflexes to help me localize where within the spinal cord I think that your pet's dysfunction is. I'm testing for pain because the presence or absence of pain helps me narrow down my differential list and helps me get a better idea of what I think is most likely going on with your pet. So those are, of course, not necessarily cat specific tips, but I think you guys in general practice certainly do a lot more exams in front of the owners and on emergency too. I know when I was an intern doing emergency rotations, I had to do a lot of these exams honestly by myself, which is tough, especially if it's like a big dog. I had to do them in front of the owners. So I think honestly just trying to communicate as much of what you're doing, because I try to put myself in the owner's position. If I saw my pet going through this and I didn't understand the necessity of it, it would seem like, I don't think any pet really loves their neurologist because we're really annoying. I'm sticking hemostats in their nose and down their throat and pressing down on their back, you know. So the neurologic and the orthopedic exam are meant to be potentially eliciting pain, and they're meant to be annoying. And so I think that's my biggest tip as far as doing them in front of the owner, is just being really transparent about what you're doing so that they can understand the medical necessity of it. And then if they are not allowing you to do your job, you have the option of saying, you know, I can either do this exam without you present if this is too stressful for you to watch, or I cannot do a full exam, but I want you to know it's going to make it a little bit more difficult for me to help you figure out what's going on with your pet.
Awesome. And then you have one more that popped up too. So Christy wants to know, do you ever record your exams to refer back to?
I don't. And I honestly wish that it was my immediate response when something like a specific gait or something like that happens for me to record it so I could show it to people in these types of lectures. I don't think it's a bad idea, especially if you're having to put the pieces of the puzzle together to get a localization. But one thing that I will do, especially if it's a pet that has a lot of cranial nerve deficits, is that I will write things down as I'm doing the exam so that I don't forget. And then I put all the pieces of the puzzle together and come up with a localization. And I want to emphasize that as well. I think as someone who gets things referred to me a lot, one tendency I seem to notice is that people are really reluctant to localize, and so they just don't localize. And I think it's in my opinion, it's not a complete neurologic exam if you haven't localized the deficits. And sometimes you can't. Sometimes it's multifocal, or sometimes it's confusing. The worst case scenario is that you just do a broader localization where you say intracranial or spinal cord. But I think it's really important to narrow down the localization, because that's a key component in creating a differential list and being able to figure out what to recommend either treatment-wise or diagnostic-wise. So to answer the question, no, I don't, but I don't think it's a bad idea.
Awesome. Okay, looks like nothing else is popping up. So you're
okay.
good.
I can talk to you guys about seizures. So I think the first thing that I tell people about seizures is that there's no need to panic. Seizures almost always are self-limiting. Yes, there are patients that will go into status. It's not that common. It's really scary when it happens, but for the most part, they will stop. And I think it's very intimidating to see a patient seize, especially if you aren't someone who sees it often. And I think the biggest thing is just to take a breath And then especially if you're seeing a patient that doesn't necessarily have a history of seizures, but is coming in through your clinic, either through emergency or like an urgent care situation because they're having seizures, the first thing that I want you guys to remember to do is check a blood glucose. Always, always, always check a BG. And you don't have to do it before you try to stop the seizure. I think it's very reasonable to try to give that pet midazolam or diazepam if you have venous access. But checking a blood glucose is super important because if they're hypoglycemic and they're seizing because of that, they're not going to probably respond to the midazolam, and it's going to completely change what your differential list and what your treatment recommendations are. It's a really easy step to skip or to forget about. But if there's one thing that people take away from this lecture, I hope it's that when you have a seizing patient, check a blood glucose, because it's going to change a lot. And if you are the type, if you've missed it before, I don't want you to feel badly about that, because I think we all have at some point, maybe not that specifically, but something else really, obvious that in hindsight, I mean, that's just the nature of being a human being, but that one will help you a lot when you're talking to owners about what you're going to recommend next. And it's also really a good reason, among other things, to recommend doing lab work in any seizing patient, because there are a host of metabolic conditions that can cause seizures in pets. And it's important to have that information. It's also helpful to have that information before you start an anti-seizure medication. So I see like part of that question. Kirsten, can you read that to me?
I know, I'm like, there's things coming up. Well, I have actually a question, and I will tell you guys right now, I call and text Flo with questions all the time. So this is not just a student thing. Like, developing a good relationship with your specialist in your area is so important. Sorry, this is a little side note, but it's so important. But also, abusing your friendships with people, no, not abusing, utilizing, taking advantage of. So this is something that like we come up with questions too, so don't hesitate to ask. There's no such thing as a dumb question. So I actually had a question for you, and this kind of goes with it. So someone just asked, if you don't have venous access, do you find rectal administration of diazepam worthwhile? And that kind of goes with the question that I was going to ask you, which was, I read an article in a study that says that giving midazolam IM has rapid enough absorption and distribution throughout the body that is going to be faster than rectal diazepam. So if you can't get it IV, giving IM midazolam in those scenarios is going to work just as fast and better. So I was going to ask what you think about that.
Yeah, I guess if I had to like rank what I would prefer, IV diazepam is always going to be or midazolam. I think some practices are moving to just having midazolam instead of having both from a financial standpoint. So if you have both, either IV is going to be best. If you don't have venous access, I would say, I agree, intramuscular midazolam would be my next choice, because it's the easiest to administer. It's easier to draw up, because rectal, you're going to have to pull up a much larger volume. It is more rapidly absorbed and more rapidly effective. And it works for IV and IM. I think it's a really good option. I will tell you that being a specialist in a referral hospital, I have very little concept of how much things cost for your hospital to purchase. So don't ask me anything like that. I don't know which one's more expensive, honestly, no clue. So I know that sometimes really things can be cost prohibitive, but midazolam is a really good alternative if you don't have venous access. Rectal diazepam, I'm trying to think if I have ever had to give rectal diazepam to a cat, because I feel like that's a little bit of a tighter sphincter. For dogs, we've done it for sure. And especially in my rotating internship, I feel like we didn't have midazolam. I'm not sure, but we definitely gave lots of rectal Valium to dogs. And I'm not super convinced that it's helpful. I have a lot of owners that talk to me about having some at home. I honestly think it's more for them emotionally than it is really for the benefit of the pet, because by the time they draw up the the medication and get the red rubber placed or what, because really you need a red rubber because it won't really work in the anus. It needs to be like fully up there. And so being able to get far enough up the rectum in order for it to be absorbed at home, I think by that time, most of the time, they're already not seizing anymore. So if I prescribe it for use at home, it's usually to help the owner feel better. And I feel like I've gotten a little bit sidetracked, but mostly rectal, hard to say, not sure.
Yeah, I agree. A couple more follow-up questions to that, which we might be talking about this a little bit later, and you probably have this on your list, but we had a question about administration if you're sending it home with owners. I typically, historically, have just sent home like pre-drawn up syringes that are kept like in a dark, of the diacetyl, kept in a dark, some sort of container, plus or minus some sort of like, some owners are like, I'm not sticking a red rubber up my animal's butt. So, I mean, it just really depends on what's feasible for people, but
yeah,
typically what I've sent home in the past.
Yeah, so ideally you would draw up at least 2, if not 2 to 5 times the volume that you would for an IV dose. And you would attach that to like a red rubber and, lubricate the red rubber and then administer that. And you get it, I mean, probably like in a cat, gosh, I don't know, like maybe this far up the rectum. Probably more than like even a 1 cc syringe would be very comfortably able to do. I think it is potentially safer for the owner than another option is intranasal midazolam. That can be sent home with owners. I think that would be really hard to do in a cat personally because they have such little teeny tiny nostrils. And for dogs, there's a whole other situation. So we could talk about that some other time since they're not cats. But honestly, it's typically a large volume with a red rubber in the rectum, and it is absorbed that way. But yeah, it's a little bit slow, and it's just cumbersome to do as well. Some areas will have compounding pharmacies where you can create like a gel that's a little bit more shelf stable than just the liquid midazolam or Valium that you would drop in your clinic.
And then there's one more question on here as well while we're talking about seizures is a comment made about seizures being very scary at home for owners.
Yeah.
And do you have any tips on explaining to owners like what is happening, what they can look for, and what they can do? Like, I guess, what is your typical spiel that you were talking to them about when you're telling them what to expect if that happens?
Yeah. So seizures in cats cats are just special. They like to do everything weird. So seizures in cats can look like a lot of things. Sometimes it's honestly just episodes of vocalization, which I think should be on a differential list, but it's not where I would go first if you had a patient that was presenting for vocalization. I would look for the things that are more commonly causing it, like pain and etc. But it's hard to, their seizures for that specific cat will look the same. It's not like, one time it looks like tonic-clonic convulsions and then another time it looks like vocalization. Usually for each individual patient, it will be consistent, but it can look like a lot of different things. So for you as a clinician, being able to recognize that if something's not quite adding up and you've done a whole workup for some other weird behavior, consider the possibility that it could be a seizure disorder. As far as talking to owners, when I have a new seizure patient, things that I will talk to them about are one, to describe what a seizure is, I essentially say that seizures are sort of like an electrical short circuit of the cells in the brain or neurons. And it happens all the time. We're all having little misfires right now. And what causes a seizure is when a bunch of those nerve cells synchronize and then they create a big enough set of misfiring neurons that are all misfiring at the same time to cause either a partial seizure or a generalized seizure. And so that's also why most often patients will seize while they're sleeping, because it's easier for the brain to synchronize when it's asleep. And it has not been my experience. I think there are some patients that they have stress-induced seizures, but by far and away, most seizures are when patients are at rest. And so I talked to them about what a seizure is, and then talk about, obviously we need to talk about what could be causing seizures, but we'll kind of pluck that out of the conversation for now, because that's a whole other different road that we can go down. But as far as, I tell them that regardless of underlying cause, if they've had more than one seizure, especially in a short period of time, or if they come in with like a cluster seizure, or if they have neurologic deficits that I can't attribute to a postictal phase, that regardless of underlying cause, we need to treat the seizures. And then I talk to them about the different seizure medications. I have found that I get more compliance from owners if I loop them into the pros and cons of the medications that are available and let them make a decision, unless there's a clear contraindication for the patient to start that medication. So in cats, I will typically reach for phenobarbital. Sometimes I will do Keppra, especially in older cats, just because it has fewer, at least it has lower sedation. And in cats, especially cats with some degree of renal disease, they might be able to get away with giving it just twice a day instead of 3 times a day. And then I talk to them about the pros and cons of those medications, and then help them pick a medication that will fit their lifestyle, because it could be literally the most perfect medication on the planet, and if the owners can't give it, then it's not effective. So that's really important, and it's important for them to understand, is there going to be follow-up associated with that medication? So for instance, I generally recommend blood work on any patient that's on any kind of medication, but specifically with phenobarbital, we're going to be doing a little bit more follow-up blood work-wise, because there can be idiosyncratic reactions that are dose-dependent. There can be ones that are not dose-dependent. And so it's important to be able to evaluate, is the patient tolerating the medication, and getting levels to help you make decisions about whether you escalate doses or switch to another medication. I let owners know that even with treatment, my goal is not seizure remission, although it is more common with cats that have just what we call epilepsy of unknown cause, or EUC. Cats can actually go into remission from that, as opposed to dogs typically do not. But I let them know that for the most part, seizure remission is not my goal. My goal is a manageable amount of seizures, which is like 1 every month or 2 would be considered really excellent control. And then I give them some sort of criteria of what would constitute an emergency. And for us, it's more than 3 seizures in a 72-hour or in a 24-hour period. It is seizures that they're having difficulty coming out of, or a seizure that lasts more than 5 minutes. Those would all be things that they need to bring into their closest emergency, or if you're open and available, the closest veterinarian to potentially intervene with something like diazepam or midazolam. And then of course there's a different subset of discussion based off of if we get a diagnosis or not. And then I don't have good statistics on like the incidence of just straight up epilepsy, but it's been my experience that for cats, in younger cats, so epilepsy of unknown cause in cats has a little bit of a wider distribution of age ranges. It's a little bit harder to nail down than dogs. So it's a possibility, unless the cat has lateralizing deficits or something along those lines. But I think infectious inflammatory testing. So my baseline workup for a cat with seizures would be to do a CBC, a chemistry, a UA, a thyroid, and an infectious panel with toxo IgG and IgM, FELV, FIV, and FCV. And then depending on your region, if there's any local infectious diseases that might be relevant to the central nervous system. And then if that all comes back pretty within normal limits, then we're either looking at like a vascular event, neoplasia. It could still be infectious, inflammatory. It could still be inflammatory, but not infectious, or it could be epilepsy. I feel like that was a lot of information, and I don't know if I went through it too fast.
No, I think that was good. I think if you want to maybe repeat one more time, like your starting lab rule out database.
Yes.
Really quick. And I think I just wanted to make sure that when you say FCV, you're talking about corona.
Yes.
Okay, so if you want to run through that just one more time, your baseline labs.
Yes. So CBC, chemistry, and so some of that is partially. So CBC, I'll give you like specific clinical instances of something that you could rule in or rule out, especially since sometimes owners will want to know why you're testing for specific things. So for instance, the CBC, I had a cat that presented with seizures that had polycythemia. So it had a PCV of like 80. And it had really sludgy blood, and so it was essentially having ischemic strokes.
Right.
So you want a CBC. You want a chemistry, and you want a chemistry partially because you want to know those things before you start an anti-epileptic, and same with the CBC. But also there are hepatic reasons for seizures. You can have hepatic encephalopathies, you can have renal encephalopathies, you could have really crazy derangements, you could have hypoglycemia. So those are all reasons. So you want to look at the systemic health. You want a thyroid because hyperthyroid cats can be predisposed to seizure events. And so it's important to know, is that a factor? It may not be the only reason the cat is having seizures, but it will make it harder to control if they're an uncontrolled hyperthyroid. A urinalysis, because I think that's just good practice to have in the context of your chemistry, but also you could look for things that cause like protein loss. And it's actually not a bad idea if you have the capability to get a blood pressure as well, and to do some serial blood pressures, because you can always have hypertension from a seizing cat that's not a primary or essential hypertension. And then the infectious diseases, and if you work with Antec at all, I don't know about the other labs, but Antec actually has like a feline profile that has FIV, FELV, corona, and toxo IgM and IgG, because those are the most common infectious causes of seizures in cats. And I'm sure you all know that FELV can predispose to lymphoma, and that's one of the most common primary brain tumors in cats.
Excellent. That was great. Thank you. I think Dr. Marshall has a question for you too.
Yeah.
One thing that comes in often in my practice, I wouldn't say often because we don't have too many cats on phenobarb, but that especially new grads might encounter with phenobarb being a controlled substance, we have chosen to interpret the law that they need to be seen every 6 months to continue with those controlled substance prescriptions. And we have clients that get a little bit cranky, that they have to come back in and get hopefully blood work to continue that prescription longer if their cats are not lethargic and having, like you said, 1 seizure a month or less. Do you have a conversation with them as far as how to convince them that it's important, besides just saying, I'm telling you to do so because it's the law?
That's a great question. So yes, so one of the things that reasons why because I mean, even from the law aside, which I think is still really relevant, is that I recommend doing that blood work every 6 months anyway in patients that are on chronic medications, because you can start to see liver value elevations without any clinical symptoms. You can see bone marrow suppression. Typically, if a cat is going to have bone marrow suppression due to phenobarbital, it's going to be within the first blood work sample that you do after starting it, but it's not impossible that they would develop other symptoms. And then checking the level, because sometimes that level, their metabolism could change, and that level could be really high without them showing clinical symptoms. And then if they're at a high level for a long time, you're going to put them into liver failure. Fortunately, cats seem to tolerate phenobarbital chronically better than dogs do. But yeah, I mean, I think sometimes it gets down to the standpoint of like, it's medically necessary for us to do this blood work, and you're within your rights to say, I won't refill this medication without annual blood work. And then, if they call and say, well, can I just get enough until my recheck next week? Then you say, here are 7 days worth of phenobarbital. Yeah. But yeah, I mean, I think that that's a really great question, because it can be a tricky thing to navigate for sure.
Those are the things that, even when we've been there a while, we want to be people pleasers. we
Mhm.
want to treat the cats well, but you also get
Yeah.
that kind of legal freak out as a new grad or something when those come to you and it's like, so thank you for that.
Yeah.
That's really good.
Yeah, absolutely. Yeah, and I think it's so helpful for me to have levels, because if they do start to have breakthrough seizures, and I had a level within the last 2 months and the level was sort of at the low end, then I feel a little bit more comfortable saying, okay, well, let's try increasing your phenobarbital without them having to come in. But then I do always recommend rechecking levels and blood work within 2 to 3 weeks after a dose adjustment for phenobarbital. For Keppra and zonisamide, you don't need to check levels. You have the opportunity to if you're curious about the therapy and whether or not something is working. If we do check those levels, I typically send them to Auburn, and Auburn's clinical pharmacology lab is incredible. Also, just side note, I know that this is a cat class, but if you have a dog that's on bromide, you can send in bromide levels and they will make treatment recommendations for you for free based off of the level. So if that's something that you're struggling with. But it's a great lab, and it's helpful for them for us to send things in, because the more that they get, the more they can establish parameters. But I don't do it routinely. I don't think it needs to be done routinely. I've done it in a couple of situations where maybe they've failed other medications, either they had side effects or it wasn't efficacious. And so Keppra is sort of like our last shot for this pet, and it's not doing as well. Then sometimes we'll send in like peak and trough levels, and you'll have to call them honestly and how to, when to draw up and all the timing of that, because we do it so infrequently that I have to call them. And it's a super helpful lab. They're very generous with their knowledge. So if that's ever something that you're worried about. Reggie wanted to say hi.
Hey, Reggie. Hey, Reg. I've got a couple follow-up questions that people are asking. So one question, actually, I might ask, I have a question really quick that I think I saw earlier that I think applies to this more really quickly, and then I'll ask this other one. So phenobarb, and I think I've asked you this before. I think there used to be a little bit more hemming and hawing about peak and trough levels of phenobarb, and you and I at it, and you were like, eh. So what is kind of your opinion, especially for us who are out in general practice, about checking peak and trough on phenobarb?
Yeah, if you're just doing routine monitoring, I don't know that it matters. I don't have people come in at specific times or give their medications at specific times for routine monitoring. If you're worried about that it's not efficacious, I think it's good to do it at a trough level to see how low it gets. And if its lowest low is below the therapeutic level, then it's good information to have if they're not having any sort of side effects. If you're worried that you're getting too high of side effects, it's good to have a peak level to know how high is the highest. And then if you're worried about a combination of the two, then I would do both. And again, because I don't do them very routinely, I'd honestly have to look up when would be the best time to do it. And Auburn is, again, a really good resource for me to just call them and say, oh, when am I supposed to do this blood test?
Yeah. I think the last one that I was looking at, I would have to check Auburn because I don't think I've looked at that one recently, but I just ran one, or one of my colleagues just ran one, and they were saying like 4 to 6 hours for the peak, and then the trough before you would administer.
Right before.
Yeah.
That sounds right to me. I was going to say somewhere in like 4 to 6. Yeah.
And then there's one more question that was asking, kind of going back to the rectal diazepam at home. She was saying that she was told that it was more so like to be administered to prevent clustering or a follow-up seizure rather than stop the current one, given the amount of time it often takes for clients to draw it up and give it or get set to give it. And so she was just wondering about the validity of that, if that is what you kind of feel like as well.
I have heard that argument before, for sure. I don't know with how quickly it acts and how quickly it's metabolized. I don't know that it really does do anything to prevent further seizures from happening, but I don't have evidence that it doesn't. And so I don't do it routinely myself, but I know people that do, and I don't think it's wrong.
Okay, I think so. I think, there's one more. One more just popped up.
Yeah.
Megan says,
sure.
Liz would like to, she said, we were taught that phenobarbital should always be the first line drug for dogs. Do you agree that phenobarbital is a good first choice for the general practitioner? I do.
I do agree that it is a good first line choice. I don't necessarily think that it needs to be the first line choice, because here's my soapbox about seizures in pets. So we're extrapolating a ton of information from the human side. There are people in human medicine called epileptologists that spend their entire career studying a specific type of seizure. So we have to interpret that information with the perspective of, we don't have phenotyping for seizures the same way that humans do, and we are basing a lot of our information, where we start is coming from their information. So that's one thing that I talk to people about, for instance, when they ask me about like CBD oil in pets with seizures, is that we're extrapolating that based off of one specific type of child epilepsy that responds to CBD, and assuming that it would work for whatever type of epilepsy dogs have or cats have. And so I think for me, I'm not really a dogmatic person. I don't say that one approach is the approach. I agree that my go-tos for most patients are either phenobarbital or potassium bromide. I seem to be a very weird person in that I really like potassium bromide, and a lot of people that I have talked to feel very fearful of using it. And I think maybe it's just because I used it a lot in residency and I used it a lot in my internship, that I like it a lot. So those two are the two that have the most data to support their use. The consensus statement from ACVIM about seizure treatment in dogs specifically basically said that those are the two that should be the first line. So from a consensus statement standpoint, yes, I think that they're both very efficacious, but the caveat, of course, is that they have a lot of potential side effects. And in my clinical experience, phenobarbital is more likely to have a side effect than potassium bromide. That being said, they're both equally, they're both very good medications. Obviously, if you don't already know this, please do not ever use bromide in a cat.
I was just going to say that. I was having some chest pain. Yeah. I was like, wait, let's clarify.
Yeah.
We do not.
So like I said, in dogs specifically, in cats, never use bromide. They might be fine, but if they die, it's malpractice. So please don't use that. So I think that there are different types of seizures. So there's reactive epilepsy that is due to an underlying disease process. And then they're like a tumor or a stroke or meningoencephalitis, etc. And then there's also primary epilepsy or genetic epilepsy or idiopathic epilepsy, whatever we're calling it these days. It seems like people change their minds a lot. And so I think I personally feel cautious about saying that there's one specific medication that should be the go-to all the time, because there are different types of seizures and I don't really know for sure that that's the case. But I will say that I reach for phenobarbital or bromide in like really, like in dogs that are more likely to be refractory epileptics. In cats, I think phenobarbital is a great medication. And then again, like I said, I think Keppra is also a really good medication for older cats, that because it has a fewer side effect potential, and you might be able to get away with giving 2 times a day medication. So as far as cats go, I will reach for either Pheno or Keppra typically first.
Excellent. We have a question that says, what is your recommended starting dose of and protocol for phenobarbital?
So for cats, I load phenobarbital. If I'm loading it because it's in the hospital and it's having ridiculous amounts of seizures and it needs to be started quick, I usually do 12 mg per kg over 24 to 48 hours. I think that if you're going to do that aggressive of a loading, I recommend hospitalization, because sometimes it can make them look really flat and really scary, sedated, especially if you do it over 24 hours. Now, I will do oral loading at home with 12 mg per kg over 48 hours. So like 3 mg per kg every 12 hours for 2 days. I think that math adds up, right? 3 times 4 is 12. And then my maintenance dose for cats, I usually am somewhere around like the 2 to 2.2-ish range. And then honestly, it's just going to be super helpful for you to get that level in 2 to 3 weeks, because that's going to tell you more about your dose than the mg per kg dose will. If it's within a tolerable level, if it's somewhere around like the low 20s, like low 20s to high 20s, that's usually like the sweet spot where you've got like a really good level, and they're doing well without seizures, and you have them on a super low dose, I wouldn't change the dose. I treat the patient, not necessarily the level. So if they're well controlled and their level's 15, that I'm not like, oh, we gotta bolster that, you know. Then I know if they start having breakthrough seizures, it's probably because that level's not really working for them anymore. But yeah, I definitely recommend treating the patient, not just the level, unless the level is high. And then you need to treat the level because you don't want it to get to a point where that taxes the liver to the point of liver failure. Did that make sense?
Yes, I think so. Good job. So just as a check-in, Lo, it is 11:50 already. Time is flying. So for those of you who need to go, because I know that a lot of you are still in class or working or both or etc. Like I said, we are recording and we're still working on getting these uploaded. But if you want to stick around and ask a few more questions, I will ask if Lo is trying to run away from us quite yet. We can stick on for a little bit longer and answer a few more questions and kind of finish up the seizure stuff if you're interested.
Yeah. Well, hopefully this was helpful, and thanks for coming.
Absolutely. Yeah, no, you're doing great. Lots of questions have been popping up. So I don't know, is there anything else that you have in your brain hole that you want to go through as far as like seizure stuff for kitties goes?
I think an interesting factoid that's not necessarily, I mean, it's seizure adjacent, is that cats with brain tumors typically present with behavior changes first, not seizures. But dogs will present with seizures most often. Like the most common presentation of a primary brain tumor in a cat is a behavior change.
Interesting. Okay, I wouldn't have thought about that. I guess that makes sense though.
I think the most common symptoms of any disease in an older cat is behavior change. Makes it tricky for cats.
Guess, like, yeah, they're very like, I'm gonna hide it till I'm dead kind of a thing.
Mm-hmm.
Yeah. We just had
really
a question pop up about how long you treat for. So is this something that you just like, how long will you treat after they stop? Like, are you gonna treat them forever? What's your kind of like plan as far as that?
As far as like maintenance seizure medication?
Yeah. Mm-hmm.
So because cats can potentially go into remission, if they've been seizure free for 6 months, I will start tapering their seizure meds if the owner wants to see if they've gone into remission, but I will not even entertain that possibility until they've been seizure free for 6 months.
Excellent. That's great.
Yeah. Some people are like, you know what? No, I'm gonna stay on the meds. It's fine.
Yeah. Oh, absolutely. If you want to, Liz, if you scroll back up, I typed the frequency of the hospital, the dose and the hospital, for loading doses and home doses. Liz was just asking what was the frequency of administration. If you scroll back up in the chat, I just typed it really quick from Lo and she was talking. So the 12 milligrams per kilogram over a couple days if they're in the hospital, lower if they're at home, and then maintenance of around 2. Okay, there's another question that popped up. People are asking for lectures on cat behaviors. Yes.
Okay.
I'm not the right person for that.
Yeah, we will definitely talk about that one. That is on my list. I thought I saw another one pop up. Where did it go? Frequency and loading dose. I may have missed this, but under what circumstances do you start seizure medications? Only after those emergent situations, or will you start after a few sporadic episodes? Ooh, that's a good question, Sierra.
Such a good question. So this is, again, why talking to the owner is really important, because it's also helpful to loop them in to that decision. So if it's a single seizure and they do not have neurologic, if their neuro exam is normal except for maybe like a little bit of postictal change, you don't need to start a seizure medication. You have the option of doing it. I always talk to the owners. I never say I'm not going to start seizure medication, but I let them know, this is not typically my criteria for starting medication. If you have 2 or more seizures in a 24-hour period, I would recommend starting seizure medication. If they come in clustering, or in status, I would recommend starting seizure medication. Postictal signs in cats are, I mean, similar to dogs. You can have blindness and then typically like ataxia or kind of just like a dull kind of out of it mentation. Sometimes it's hard to interpret, but if you have lateralizing signs, then it's not a postictal change. There should never be a lateralization with postictal. It should be symmetrical. So they could have slow CPs, but they should have slow CPs in both hind limbs or both forelimbs or all four. Well, you'd hardly ever get like forelimbs without hind limbs in that situation. But if you have like, they're circling to the right, it's probably not a postictal change. You can have, you know, vocalization and sort of that weird sort of behavior. I will say, like, it's not always easy, and if in doubt, I would start the seizure medication, and then if they go 6 months without seizures, then you just stop it. But and then of course it's important to get a good, I didn't really talk about this, but it's important to get a good history, and shame on me because that's like the most important recommendation is always get a good history, because toxin exposure should always also be a differential for acute seizures.
Yeah, that's good. So new question with more questions.
Yeah.
After a seizure has concluded, how long do you give mentation or other neural abnormalities to normalize before you're worried about permanent changes?
The postictal phase can last anywhere from like minutes to a day or two. So that is a tough call to make. Sometimes I think that it's within normal limits if they're still sort of just acting like a little bit out of it. Now, if they're not like coming to, like if they're maybe just acting a little bit more anxious or they're a little bit ataxic, that's different than like my cat is sort of a flat pancake for 2 days. That I would be more concerned about if their mentation is abnormal in like the affect. So the type of mentation, if they're inappropriate, is a little bit harder because that could be a postictal change. But if they're like super dull and they're not coming out of it, I would be more concerned about potentially some underlying pathology. And sometimes, and this is not super common, so I don't want this to get like frustrating, but just to have in the back of your brain when you're like, I don't understand why this cat is just like not coming out of this, you can have non-convulsive epilepsy. And so when I have a dog or a cat that's seizing and diazepam just doesn't seem like it's really doing the trick, if you have injectable pheno, which is that a thing that people in GP carry?
I do not. I don't think it's very common.
Yeah. Okay, well then never mind. But if you're an emergency doctor at a specialty hospital or doing an internship, then I'll give a 4 mg per kg dose of pheno IV if they're still seizing through diazepam.
Have you ever gone to like propofol CRI?
I don't think I have had to personally, but I will if I have to.
Yeah.
Yeah, I guess my like triage of things for something that's actively seizing in the hospital, if you have these medications available to you, would be a barbiturate. My hair's doing something crazy. Sorry. A barbiturate, if that's not working. If you have injectable pheno or Keppra available, I would do that. I would do a couple of doses of that. Then I would do like a midazolam or diazepam CRI. And if those things aren't working, then I think propofol is super appropriate. I would try to get that thing to stop seizing.
Yeah.
So you can skip the pheno and Keppra step if you don't have that available.
Yeah. Awesome. So one more, do you see many cats that you diagnose as idiopathic vestibular, or do you feel like a lot of those end up staying at GP?
That's a great question. I don't know. You know, I think it's possible that they're staying at the GP. And interesting maybe note about that is that, so idiopathic vestibular in dogs is an old dog disease. Idiopathic vestibular disease in cats is not specifically in older cats. So that's just an important little factoid to know when you're making a differential list.
Because cats can do anything they want to do anytime.
Yep.
Sure. Do you want to give a quick little blurb or a little quick summary about what you wanted to go through about vestibular disease in kitties? So now that we're kind of touching on vestibular.
Sure. So for me, the top differential, okay, let me back up. First thing to know about vestibular disease is that you cannot rule out central disease based off of exam alone. It is not possible. You can make it more or less, you can make it less likely. So if I have a patient that has symptoms of just like a head tilt and facial paresis and maybe Horner's, then I'm more likely to believe that it is peripheral because those three things hang out together in the bulla. If they have a really dramatic head tilt or a really fast nystagmus, that's typically peripheral. And so I like to think about it as a teeter-totter. And so if you have a teeter-totter and like the fulcrum is the brainstem, then the further out from the brainstem, the more your teeter-totter is gonna tip, right? So if you have like an adult and a child, but they're both close to the middle of the teeter-totter, it's not going to really shift it that much. But if you have an adult out here and a child out here, it's going to go like this. So the further away from midline that the deficit or the dysfunction or the lesion is, theoretically the more dramatic the vestibular symptoms will be. So that might be counterintuitive. The more dramatic a vestibular patient is, the more likely I am to believe that it's peripheral. And there was a study somewhere, I don't know what poor resident was stuck with doing this, but there was a study that showed if the nystagmus is faster than 60 beats per minute, it is statistically more likely to be a peripheral lesion. So with all that being said, you can have a higher index of suspicion for peripheral disease, but you cannot technically rule out central disease. And then when I'm making my differential list, if it's peripheral, the most common cause of peripheral vestibular disease in cats is otitis media interna. But other really good differentials are things like idiopathic, especially if they don't have any other symptoms, like they don't have like brainstem stuff going on. And then, what was the other thing I was going to say? Oh, like a polyp. I don't think I ever see polyps because you guys are all really good at finding those. I don't think I've seen a polyp in my entire life.
Awesome. Yeah, I'm glad that you brought up the point about the most common cause of peripheral vestibular disease in cats being otitis media, because I think so many practitioners get scared when they see this cat with a head tilt, especially older kitties, and having sort of like cardiovascular, so like vascular emergency, stroke,
Yeah.
Tumor, embolism type thing. And I think we so commonly forget. And just because the cat doesn't have disease on the external canal, so just because you're not seeing redness in the external ear canal, does not mean that there's not inflammation and disease on the other side of that tympanum. So getting good at looking in cat ears is really important. I'm sure the neurologist and the dermatologist can attest to that, but like coming from a general practitioner, Ashley says, yes, scope those ears. Yes, queen.
Well, it's funny because actually on the podcast interview with Ashley, we talk about the fact that like I don't really do otic exams, which probably makes me a bad person. But like the majority of the time that I've seen animals that I've diagnosed with media interna, even after doing an otic exam, I was like, I don't know, looks fine to me. But I think from a non-neuro standpoint, yes, I fully agree with you, but I just thought it was funny that you brought that up.
Oh, for sure. Well, actually, like the 2 kitty otitis medias that I've had recently have actually been confirmed by a dermatologist, not a neurologist.
Yeah, for sure.
And they looked at the eardrum and there was like, yeah, on the other side of that eardrum is really cloudy and really sketchy. Patient was treated with antibiotics and antiemetics, and so Serenia. And then the owner picked up meclizine over the counter and gave that, and cat did great. So I think we have to know that otitis is a tricky thing we often forget about.
Yeah, once upon a time, VSC and Linwood had both a dermatologist and neurologist, and that was really fun because we would do the imaging and we'd be like, yep, it's otitis. And then we'd call down the dermatologist and she would do video otoscopy and the myringotomy, and we would just be like, there you go.
And then the eardrum, you poke through it and you're like, there's just cheese and like icky things happening. So especially kitties, Ashley's saying, especially cats, they like to have otitis media without obvious external canal issues. And I would 100%
Yeah.
second that from a GP standpoint. So
Yeah.
Excellent. Well, I want to be respectful of everyone's time. Surprisingly, even though we're still going and it's 15 after, like almost everybody has stayed logged on. So you're everybody excited. Does anybody else have any final questions for Lo, for Dr. Curtis? You can still, if you guys come up with questions afterwards, like I said, we're working on getting the recordings available. You can absolutely contact her. So that is something that you can 100%. I want to also make another shameless plug for Lo. If you guys are getting into the veterinary social media world and podcast world, good for you. If you're not, 100% you should be. Lo has started a podcast called Thrive DVM Podcast, and it is absolutely fantastic. So that is another way that you can listen to, get connected with her, talk about a lot of different topics. She has a really good episode about studying. She has a great episode about internship residency, but also a lot of mental health, kind of working through things type episodes, and it's great. So that's another place that you can check her out, is Thrive DVM Podcast. But if you guys have questions for her, definitely don't hesitate to reach out to any of us, and we can forward those questions. So yeah. Thanks for coming, sis.
Of course.
I'm so happy. Thank you guys so much for joining us today.
Thank you, Lo.
Of course. Thank you for having me.
You bet.
Absolutely. All the thank yous are popping up on chat.
Yeah. I have one more comment about that podcast, as well as, which I'm typically not the demographic, but just veterinary podcasts in general. It's a great community. It's a great place because these hosts have interesting people on. It's a great place for me to learn about other people in the community and then reach out and connect with them too. And so just a shout out for that in general. If you want to get connected in, that's where it starts, is reaching out to people and say, that was cool, tell me more about it. So that's great. And yeah,
Absolutely.
really good podcast.
Absolutely. All righty. Well.
Oh, yeah, and tomorrow mentoring, don't forget, it's going to be fun. I'm really excited for that conversation.
Yeah, me
and,
too.
I think that's it for today. Thank you for joining Cat Class, and we're out. See you tomorrow.
Yeah, guys, tomorrow, 11 o'clock. I'm not just excited because it's me, but also it's me. See you guys tomorrow.
See ya.
Where's Ella?
She's sleeping on Fred's bed.
Aww.